Hello again, and welcome to another roadshow segment of Doctor in the Dugout. I'm your host, Dr. Alan Beyer, and I'm thrilled to be joined today by one of my new partners and associates at both Newport Orthopedic Institute and Hoag Orthopedic Institute, Dr. Taylor Dunphy. Taylor, thanks for being here with us today.
Thanks, Alan. I appreciate the invitation.
Well, Taylor's joined our group now as another one of our cadre of sports medicine specialists. He's fresh out of his sports medicine fellowship training with another good friend of mine, Dr. Jim Taboni up at USC. How was that year fellowship experience for you up there?
It was quite an amazing year. You basically learn from some of the experts in the field of sports medicine, and from that you get to go and actually practice on collegiate athletes and then athletes of all ages.
So I think a lot of people who are seeking out treatment for a sports injury don't necessarily realize that, you know, most of us who did sports medicine fellowships, including me back in the day, really learn a lot of the stuff that we're using to treat these people in on-the-field training. How important is the sideline aspect of your sports medicine training when you're taking care of these athletes?
I'd say it's paramount because you get to see the injury right in front of you. You get to evaluate them right away before swelling comes into play, and you get a good sense of what the ligaments are doing. As you wait longer and longer, then you get stiffer, for example. If you're on the field, you get a good Lockman, good exam to know what really is out.
I'll tell you, it's really amazing too these days how those of us who are sitting at home watching, at the pro level anyway, get to see these injuries occurring in 16 different angles, 5 different speeds. I mean, it really is kind of added a whole new ability to understand the forces that these athletes are being subjected to when they get hit in a certain way.
And it just is no longer pros, even high school students now. I had a high school student come in last week with a video from him lacrosse injury as he broke his clavicle. So it's influencing all areas of sports.
Sometimes it's not always for the better either, as we'll get into in a little bit if we talk a little bit about concussions and things like that. So I think the other thing that I really would like to get across to our listeners is how today's sports medicine doctor, who's fellowship trained, is really looking to take care of athletes at all levels, from peewees and football all the way up through major college and pros, and to the weekend warriors as we hit our 50s, 60s, 70s, and continue to abuse our bodies in various ways. I mean, how are you able to take what you learn at the very high college and pro level and apply it to the public at large when they're just playing their recreational sports?
So the term sports medicine is often confusing to patients because these people you're seeing didn't actually injure themselves playing sports, but the injuries themselves are, quote unquote, can be caused by a sports injury. So if you come in with a 60-year-old who's not playing football, he can also tear his rotator cuff or hurt his clavicle in the same way a professional football player could. So the principles apply to all ages, and the management is just a little bit different between a pro and someone who's a weekend warrior.
And I think we're also seeing a higher and higher incidence of the repetitive use kind of injuries and phenomena. I mean, for instance, the young pitcher who is needing Tommy John surgery at the age of 16 or 17 or 18 as opposed to professional. These are repetitive use injuries, not just one-time traumatic injuries. We're seeing a real explosion in those in adolescence, aren't we?
Exactly. There's these kids now playing sports year-round. So the periods where they used to have summer break or times off are now spent training. So you have these overuse injuries that are common in young age, also in older adults, people who are doing activities above head. Lifting things can also cause rotator cuff issues in a degenerative type pattern.
So you said something there that I want to amplify a little bit for our viewers, and that's the year-round aspect of things. We happen to live in a climate where you're able to avail yourself of outdoor activities, 12 months a year. I grew up in a place back in East in New York where you couldn't avail yourself of out-of-door stuff for almost half the year. I don't know that that's necessarily a good thing, especially with our youth. When a kid today is identified as being a pitching prospect, for instance, suddenly he's throwing January through December, whereas if he lived in New York or Connecticut or somewhere back east, he's not throwing, at least at the same level, out of doors 12 months a year. I mean, that's really turning out to be a bit of a double-edged sword, isn't it?
Yeah, and as a role as a sports specialist, I try to counsel some of the parents more than the patients that there is a limit that these young athletes can handle. So if you're having shoulder issues, we usually slow them down, take a time off, and that'll actually make them feel much better. Rushing into surgery for a Tommy John is not necessarily needed for a lot of injuries. Just time and just decreasing the workload is very effective.
I also think, unfortunately, the increasing financial pressure, the increasing cost of going to a college, getting into a college that your parents want to get you into, are suddenly putting all kinds of stresses on these kids that, well, maybe you saw when you grew up. I certainly didn't see when I grew up. And I don't know that that's really a trend for the better.
Exactly. There's a long life ahead of these athletes, so you got to make sure that they're being safe. Concussions is one of those issues where the goal is to get back on the field as soon as possible, but in reality, we need to take our young patients first and look at their whole lifespan before we push them out in the field.
Let's talk about concussions for a minute or two before we move on to a couple other things. There's been so much stuff about it in the last couple of years at every level, from the NFL on down. We certainly treat the concussed athlete way differently than we did 20 or 30 years ago. I mean, it was almost a badge of courage 30 or 40 years ago to sustain a concussion in a football game and get back in there. We've gone 180 in the other direction now, haven't we?
Exactly, and it's kind of a spectrum. NFL, most aggressive; high school level athlete, the most conservative. So if you have any symptoms of a headache or loss of consciousness, obviously, we would sit you out definitely that game, and you have to do a checklist of different activities in order to be cleared to play in the next week. So often these athletes are out for several weeks before they're ready to go back.
And even at the pro level, we're seeing, neurotrauma specialists at every NFL game, a concussion protocol, which is a totally new term that we never heard before at the professional or collegiate level. If somebody gets significantly concussed, they've got to pass certain tests before, even at the professional level, they're allowed to go back in.
Yeah, and the data is limited right now, but it's concerning with some of the studies out there. So everyone's taking it very seriously, and especially in the younger age population, you got to be very conservative.
And I think this applies to soccer too, with heading and head-to-head contact. When two kids are going up for a headed ball, we're certainly being more conservative in the concussion approach in soccer as well.
Yeah, I was the team physician for USC women's soccer last year, and they had as many concussions as probably football players did. So it's not just a football injury.
At least they don't have a helmet on their head, so they don't feel their head's a weapon like the football players do. So let's talk a little bit about some of the stuff that you've learned. You're fresh out of your training. Tell us about some of the newer things that are happening in the treatment of sports injuries, specifically knee injuries, shoulder injuries. What's out there now that maybe wasn't available to us 5 or 10 years ago?
So previously in the past, big incisions were the way of the game, if you will, but now everything is done essentially minimally invasive, with the size of about a centimeter incision, several around the knee or around the shoulder. And using a camera and some arthroscopic tools, we're able to accomplish big surgeries in small little spaces.
The major advantage to not having the big old incision like the old days is less soft tissue trauma, so the rehabilitation ostensibly should be faster.
In some cases it is, but also you're still repairing it the same way. So you have to protect it, but the pain, the stiffness, some of the things that are complications in the past have now been improved.
And I think we have to also keep in mind that we're doing these things for better outcomes, not for better cosmetic results. Because I think as much as we aim for a nice cosmetic result, those of us who do an orthopedic surgery, for the most part, cosmesis is not our #1 priority.
I agree with that.
Okay, so how about some of the new things in treatment of cartilage injuries? There's a lot of stuff that's happened now, some good, some bad. Let's talk a little bit about cartilage implantation, where we take a patient's own cartilage and culture it and reimplant it. What's the state of the art today?
It's pretty cutting edge. So if you have an isolated cartilage lesion, like basically it's a pothole in the pavement, we can take your own cartilage in one surgery, send it to a lab, regrow it, make a sheet of tissue of your own cells, and then reimplant it. And that's actually shown to have some of the best results in these isolated cartilage lesions.
But I think, like always, I think the key thing you said there is a pothole in the highway, not where the whole highway's surface has been absolutely disrupted. Because we see a lot of patients with significant arthritis who say, why can't you just grow new cartilage and put it back in for me? We're not there yet, are we?
Science is not there for global arthritis. The gold standard is still a total knee replacement if you have arthritis in all areas of the knee. But if you have a isolated single lesion or 2 lesions, some of this new technology is definitely the wave of the future.
So we hear a lot now about 2 other things that I want to talk with our viewers a little bit about. PRP. What is PRP? When do you use PRP? What's the value of PRP?
So PRP stands for platelet-rich plasma. Essentially, it's your own blood spun down in a centrifuge to concentrate some of the growth factors. These growth factors have been shown to decrease some of the inflammation in tendons, and also they've been used in arthritis to decrease some of the inflammation of the lining of the knee.
So it decreases the inflammation, but doesn't grow new cartilage cells inside the knee. That's an important misconception, I think.
True. So the PRP is just setting a good environment for the knee. It's not giving the cells that are needed to grow new cartilage.
So let's go to the next step. Speaking of cells to grow new cartilage, stem cells are all the rage. You see, can't read a newspaper without seeing a full-page ad about stem cell injections. Tell us where we're at right now. Is the time really here yet, or are we still kind of on the early adopter curve and we don't really know yet on stem cells?
It is definitely on the early side, in my opinion. Some people swear by them, but the data in large studies is not there yet. So the essence of a stem cell is you find it in a body. It can be from fat, it can be from bone marrow, and you have these cells with the potential to grow into cartilage or grow into certain tissue, with the hope that this will help the arthritis that you have. But again, it's kind of the early stages of this.
So we don't really have any good data yet to show that stem cell injections can reverse an arthritic knee, grow new cartilage, and hopefully that patient avoids a knee replacement.
Yeah, the advertisements you see probably are a little bit too good to be true, but there is some data that's proving that in the future, hopefully we can have that technology work.
Well, Taylor, I think this has been very elucidating for our viewers. They can all reach out to us at orthopedichospital.com, the Hoag Orthopedic Institute website. Thank you so much for taking time out of your busy schedule, taking care of the peewees, taking care of the pros, taking care of the seniors, to clue us in a little bit as to what's going on, and we'll see you back here again soon, I hope.
Thanks, Alan. Appreciate it.
Thanks very much. Have a great one. We'll be doing some more of these episodes as time goes on, so stay tuned, and thanks a lot for being with us today.